Afternoon. I'd like to call the meeting of the December 14, 2002 Health and Human Services Board meeting to order. Hello, everybody. Hello. As you can see, we sort of readjusted the setup because the last time it didn't seem to work properly, and as a result, we've hid the staff behind us, but I'm sure we'll be hearing from them whenever the appropriate time is there. I would like to say that dealing with the state process of how we set up this very committee, we have the opportunity to have two consumer people on this board, and at the next board meeting, our good friend Terry will be introduced and put on this particular board. Would you like to tell us a little bit about yourself? And so, because we shared it ourselves the last time, would you tell us about, even though you're not a member at this point, but you're going to be?
Well, thank you. I am very honored to be considered for membership on this board. I'm very proud to be a resident of Buncombe County. I've lived here for about 20 years. I'm a retired systems analyst. That means I develop programs for large companies back in the 70s, 80s, and 90s. Since I moved to Asheville, I've been involved with a number of nonprofits, organizations like Basic Legal Services and the Council on Aging and Children First. And I love the word advocate. So I'm really pleased to be here. I've had a little to do with the health department. Several years ago, my husband had a barbecue. And I don't know if you remember, but we had a hepatitis scare. And I had the privilege of getting probably 200 people from literally all over the country, including Madison County, gamma globulin shot, and it was quite eye-opening to me because I talked to health departments in several states, and none of them were even as close to being as responsive as Buncombe County was. So I'm very pleased to be here.
Well, thank you so much, and we're glad to have you on board. And we'll be hearing some more from you. And since you're retired and you're not dealing with all these big things, I need some help personally at my home. So anyway, but thanks for agreeing to join us, and we appreciate you taking that last position. Thank you so much. Have you had a chance to look at the agenda? It was sent to us, and there's nothing added to it. I would like to remind you that in accordance with the State Government Ethics Act, it's the duty of every board member to avoid both conflicts of interest and appearance of conflict. Does anyone have anything of that nature from looking at the present agenda? Most of the agenda today is going to be dealing with finances. But anyway, hearing none, then I'll ask you if we will approve the agenda. Do I have a motion to approve the agenda as presented?
So moved.
Second. Any questions? All those in favor say aye. Aye. So be it. We also have the minutes. They were presented to us by email, and does anyone have any suggestions, additions, deletions to those minutes? Move approval. Move approval. Have a second? Second. Moved and seconded. Any questions? All those in favor say aye. Aye. So be it.
We do need to go back a minute and entertain both a motion and action around recommending the girls' appointment to the board.
Oh.
Make it official.
I so
I'm
moved.
sitting next to the attorney.
I so moved that Terry Van Dyne be appointed as an advocate member of this committee. Is that right?
That's right.
I second that.
Moved and seconded. Any discussion? Thank you. Glad to hear that. All those in favor of make a recommendation to the Board of Commissioners that we accept her as a member of our board, please say aye. Aye. So be it. Thank you. I appreciate you keeping me straight. Now, we're going to get into the official part of the meeting, and Jim, whom we will learn to hear a lot from. And so, Jim, if you'll just take over from here, we appreciate it.
Thank you, Mr. Chairman. Good afternoon. It's a pleasure to be here for you today. And as I was thinking about how to introduce talking about budget, and of course it's a fascinating subject to me, one that I truly enjoy. But one of the things that I was thinking about in terms of what this does is providing orientation for the board members. And when I went back and thought back to what it was like when I had new employee orientation, I had a nice big thick notebook, and they went over all these policies and procedures, filled my head with them, and I signed off saying that I understood and agreed to abide by every single one of them. And I can remember now looking back on that and thinking that was crazy. I had no way to know what all those were, but I did it. Unfortunately, part of orientation is sitting back and being given information for you to digest. And so unfortunately, that will be part of what this presentation is about. But I also want to take this as an opportunity to ask you to give us feedback and give me feedback in this process, because one of the reasons for having this consolidated board is to really delve into and really address the health and safety and well-being issues that are facing us as a community. And each member of this board is here because of the unique perspective that you bring and your ability to provide feedback to us so that we can help the community and the community can help us to implement the mission and vision of Buncombe County Health and Human Services. So it's not an accident that any of us are here at this point, and it's not an accident that we're going to talk about from the very first budgeting from a balanced perspective, because we believe and have put into place processes that make budget a vital, lively portion and not something that's to be afraid of or to be scared of in the pursuit of implementing your mission and vision. One of the things that I hope that you'll see in this process is that we do look at it from a balanced perspective, and that we have brought the budget to a point that it is an iterative process, that we have a dialogue of what we do and how we present things. So with that in mind, and hopefully with your feedback and your discussion today, that will help us both in understanding the budget and going forward. It'll be a wonderful presentation for you. As much fun for you as it is for me. One of the things that drives all of the work that we do, we're driven by policy, law, and statute. So I was thinking about this as well. We are under so many, literally hundreds of policies that we must follow, probably in the thousands if we were going to go into the details, that drive the work that we do. And I emphasize that because that tells you that most of what we do is mandated by law, policy, or statute, and there are guidelines that we don't have a lot of flexibility about. But what we do have flexibility about is how we take the whole and make it work with those policies and procedures that we have. We're probably, between health and DSS alone, probably one of the most audited organizations anywhere. Both internally, where we have a very strong internal audit process, where we look not only from a programmatic standpoint to assure that we're doing compliant with the programmatic requirements of the program, but that we also have a physical compliance audit and internal audit person, so that we make sure that the physical and the program are working together as they should, and that they're linked appropriately, because as you'll see, there are significant implications if we do something wrong. And if we do something wrong with not only from a programmatic standpoint, but from a financial standpoint, there are huge liabilities that this county is potentially exposed to. So we want to minimize those as much as possible. So when we look at what we do, we approach this from 6 broad perspectives, or 6 broad and fees. And we're going to talk a little bit in depth about each one of these, but just to go over those, we focus on core, we balance our perspectives, we'll talk about what that is, we reallocate resources to meet needs, we build partnerships both internally and externally, we use information technology to bridge gaps that we may have, and we communicate. Now, do we do all of these perfectly well? Well, no organization does all of these perfectly well. But our goal is to make sure that we do those in the most effective way that gets the best results for the people that we serve. So if we think about focusing on core, the things that, what this really does is allow us to say, when we go back to the law, policy, and statutes, those things that are required absolutely by law, policy, statute, or commissioner directive, those are the things that we're going to do. If those things are not part of what we're mandated to do, but may be important, then we make sure that we do core first, because nothing else can get done unless we assure that core gets done. And so that's where we put our primary focus on that. By doing that, what that allows us to do is, and you'll see some things that we've been able to do, is to take resources where we may not have been focused on the specific core, but it was important to support those organizations or those particular projects in the community. We reinvested resources in those particular areas to be able to do not only our core services, but also to do some additional services that if those services were not provided, our core services and our cost related to that would dramatically increase. Staying balanced. Staying balanced, that's a good maxim for anybody to do, to agree to stay balanced. But when you're looking at it from the standpoint of health and human services, it's a process that probably many of your organizations do, whether consciously or unconsciously. It's about making sure that, in this case, fiscal doesn't make all the decisions based solely on a money perspective, and program doesn't make all the decisions based solely on program. I'll give you an example. If we made all of our decisions based solely on the picture that we have right now on financials, we may not have been able to do innovative things. We may not have been able to do those. We may have said, on the other hand, from a program standpoint, that it's the best practice to make sure that we have one caseworker per citizen in this county. Well, that's absolutely may be the best practice, but that's absolutely not going to be what you're going to be able to do long term and sustain any organization. So what we've done is we've employed a process that we call a balanced scorecard, and it's a very well-known process for budgeting and for looking at the way you do that. So we do 4 specific perspectives that we look at, and they build upon each other. So when we're looking at balanced perspective, the first one that we look at is organizational capacity, and that's that foundational structure. What are the tools that you have to have, whether that's a building, whether that's staff, whether that's equipment, that you must have in place in order to build that foundation. Now, if you've been a part of any of the boards previously, or if you've been a member of the community and seen what we've done, the county has made a significant investment in doing just that. By creating at 40 Cox Avenue, where we created the integrated service model of health and DSS, of linking those public health systems with income maintenance programs, we built a system, a foundational system that allows a customer to access those services. We also put in infrastructure related to both the building and renovation, and also from an information technology standpoint, to maximize the resources that we have there, the staff that we have there, so that we can also make sure that the experience from a client or patient perspective is positive. Because ultimately, as you'll see, that's the most important one. The next process that we look at is from an internal business process. What is it that we do and how do we do it? There are lots of things that we may do, but we want to make sure that we're doing it in the best way that provides the best outcome for the client. That goes back to also, if you're only focused on one of those, you're only focused on the internal business process without the other perspectives, you may lose your perspective overall and have a large adjustment. Financial stewardship Well, that's a key component as well, to make sure that the resources that you have in place are being used to the greatest extent possible to serve the greatest numbers of people possible, to get the best outcomes possible. And so we do that in a way that hopefully is interactive with those. And then finally, it's deliberate that client, patient, stakeholder is at the top, because that's the most important. All the others feed up to what are the outcomes that we want for the clients, patients, and stakeholders. Clients, people that we serve directly, patients that we serve through the health. Stakeholders are not only those people that directly receive our benefits, but our taxpayers and citizens in the community that receive the benefits. Example would be food and lodging, health inspections that we do of restaurants. Those people, a lot of those folks that go into those restaurants may never interact directly with health, DSS, or Parks, Recreation, and Recreation, but if it weren't for our food and lodging and doing those health inspections, there may be a serious public health issue related to that if we didn't do that. So those are the ones, that's the top one. Now, how do we do those together? How do you keep all those perspectives in balance? Well, what we've done is we do a budget process that doesn't look at one particular perspective. We have human service planner evaluators, and their role in working with the different departments is to be that link between fiscal and program, and also to be that link between that particular program and the overall organization. So they are specifically equipped to have an overall perspective of what's happening within the organization, both from a programmatic as well as a fiscal standpoint. So when you're looking at developing a budget, what they do is they meet with the particular divisions and they go over what their priorities are. They see if those priorities are being met, if they're being met in the way that they like having them met, or if there are different ways to approach implementing or achieving those priorities. Then they look to see, okay, what is, of all those initiatives that you're doing, what is your priority of those? How do you rank each one of those? Then, after they've done that, then you put the cost to those and you decide how much does it cost to do that. And then when you look at that and you say, okay, well, what are the resources that you have available to do that? And say, here are the resources that you have. And then you simply, in essence, go down the list and make sure that when you draw that line of where your resources end, that all of those things above that line are able to be funded. And if they're not, then the program gets to decide what are the things that we need to do that's below that line that our resources don't allow. Do we need to shift resources? Do we need to move the priorities? Do we need to change? That's where that can happen, and where also the planner evaluators have the perspectives of knowing what's happening within the overall organization to see where there may be other opportunities. If those priorities have got to be funded and there's no other alternative, then that's where the broader perspective of looking to see how you can take resources or reallocate resources from somewhere else. So this balanced approach has helped us, has served us very well to make sure that our primary focus is the customer, client, patient, stakeholder. But all of those perspectives have to remain in balance. If you get out of balance or focus on any one of those perspectives to the detriment of the others, you will always have to make a strong correction. And a strong correction means pain. It means paying either internally, it means paying externally to the people that we serve. So we don't want to get in a situation where we're having to make a strong correction based on decisions that we've made. There may be some external ones that come our way that cause us to do that, but internally we don't want to have to be the ones. We want to be in balance and stay in balance, and that's how we approach our budgeting perspectives. Reallocating resources is a great slide, and Mandy points out to me, you know, if this slide would be perfect, because we do reallocate resources. We do take, if we're doing a program in one area or we're seeing that something's not effective in one area, and we see something needs to be done in another area, if we have resources, we're going to reallocate those. Whether that's dollars, staff, space, positions, no matter what it is, we're going to reallocate those. But we always do that with in mind, and this is where Mandy says we need to have a graph that shows a safety net under there. We don't ever reallocate resources. We don't ever change the way we do things without making sure that there's a safety net underneath. I'll give you an example. When back in 2009, we entered into, and you'll see some information about this, we entered into a smart partnership with Western North Carolina Community Health Services. We were providing primary care for children and adults, and also prenatal care for children and adults, in a completely unsustainable model based on the numbers of people that needed to be seen. The federal government was going and has stressed and continued to stress that the federally qualified health center is the model that they support for access to care for the under and uninsured in our country. And they provided financial mechanisms to help support that. But we've also said this is a great partnership opportunity. But that was a scary time. And if you were a part of that board at that time or a member of the organization at that time, you understand that that was a very scary time because we believed that it would work, but we also wanted to make sure that when we reallocated those resources that we had a safety net available so that if something didn't work, that we could pull that back and we could be able to provide those services to it so that the citizens that depended on those, some for their lives, would be able to get that. And so we were able to, through the process that we're going through here, to build a contingency, to build resources to be able to have in case that happened. Fortunately, it didn't happen. It worked amazingly well. But that tells you that when we do go through that process, we don't do it without having a safety net underneath us to make sure that we address those underlying issues so that people that receive our services don't get hurt. Community partnerships. Building smart partnerships. We are dedicated, and you'll see in a minute how we are dedicated financially. We are dedicated to making sure and understanding that we cannot be the end-all be-all of provider of services for health and well-being and safety in Buncombe County. We cannot do that, and that's not even our role. But we know that there are significant partners in this community, many of whom are around this table, that have responsibilities for the same populations that we serve. And to the extent that we can partner and use the expertise of those partners to provide those services in a way that not only gives the client a better outcome, but also strengthens our community and our safety net web of resources that we have, we want to do that. And so we engage in community smart partnerships all over, as many as we can. And one of the great things about being on this board is that we would love to hear from you. Are there things that you're working with in your organizations or your nonprofits or your particular areas of expertise that maybe help us to engage in partnerships that will not only support the community, but that will also enable us to provide those core services that we're the only ones that are going to be able to provide, either by law, policy, or statute. So this is by no means all of our partners, but just hopefully if your organization is not represented here, please let me know and I'll make sure I get that up there in your slide. But most organizations, we have strong partnerships with many of these organizations to not only provide services, but either to provide working agreements around sharing of information or to actually do services that we normally not have been able to provide. So what's our criteria? It's to provide or assure services through performance contracts that the county would otherwise be required to provide. Now, performance contracts is in red for a very important reason, because we don't ever enter into a contract with an organization without specific performance measures in place. We want to make sure that we hold ourselves accountable. We want our partners to hold us accountable, but we also know that we have to hold our partners accountable for the resources that we give to them to make sure that we get what we're paying for and that the citizens get what they deserve and that the taxpayers get a return on their investment to be able to know that what we're doing is the right thing. So our smart partnerships and our process for doing that, a lot of times we will begin with a competitive examination process. Sometimes that's done through a request for proposals. Sometimes that's done through our own internal process of looking to see who are the partners that are out there that may be able to help us in accomplishing our mission. We always look at a performance-based process. We always provide continuing, ongoing evaluation of those contracts to make sure that they're delivering those process, much to the delight of the people in the agencies that get to review those contracts on a regular basis. Everybody loves to review contracts. That's one of the most favorite things for people to do. But we do that, and we do that also, as I said, just to hint into a little bit, it's about fostering community ownership. If we said, let us handle this, let us take care of the masses, then what does that do for fostering community ownership and for helping to create and support the organizations that are in this community that help us, that we couldn't do it alone? And also, it provides simplified access to services for working citizens. An example, I can think of, we have partnerships with ABCCM, Evelyn Charity, Swananoa Valley Christian Ministries, and we do that specifically around crisis intervention programs for heating and cooling assistance. Now, we could have everybody come to DSS and do that, but those folks, especially where they are in their communities, those folks go to those places for assistance now. So why does it make sense for us to say, go to ABCCM and they'll pay $50 on your electric bill, and then if you'll go to Evelyn, they'll add another $50, and then come to us and we'll do another $50, and we'll pay that $150 bill for you? That sounds crazy, doesn't it? But that was a process that we used to do a long time ago. And we would ask and require people to go to those different locations to do that. Now we contract directly with those organizations, because not only do they not have to coordinate among themselves, but they also have additional programs that they provide that can maximize the use of their resources so that they can help the people that come to them with their own resources. And we get a bigger bag, and we leverage resources that not only that we're providing, but that those organizations are providing. So for this year, in performance-based contracts between Health, DSS, and Parks, Greenways, and Recreation, we contract out $13.5 million. That does not include all of the contracts that are sort of those like interpretation services or other contracts that we may have that do not have a specific dollar amount. $13.5 million. An example. Several years ago now, we were invited to a meeting in Hickory to hear from two child care subsidy providers. One was from Mecklenburg and one was from Southwestern Child Development Commission. Southwestern Child Development Commission manages this child care subsidy. DSS is charged with providing child care subsidy for low-income individuals to help working parents to provide daycare for their children so that they can become self-sufficient. Southwestern provides that service for a seven-county region in the West now. Already, we're doing that. They were both an operator of a child care facility, and they were also the administrator for the DSSs in that seven Western County region. They came and presented and said, you know, this is what we do. That was in April. By July 1, we had a contract in place with them to do the administration of our child care subsidy program. The reason that we jumped on that was twofold. Some of those were our own reasons, but one of the main reasons was because they're an expert at it. They've got the process down. They do it every day, all day. They have great relationships with the state, particularly around funding, particularly around policy development. They also have the ability to allow us to reallocate resources. The DSS budget is a weird animal. When you do the DSS budget, it is one that allocates. It's a cost allocation system. Essentially, is what it is. It's a big cost allocation system. So when programs do a particular work, part of the cost is not the cost is not just attributed to what it takes to do the child care subsidy piece by itself. It allocates all of the other overhead, administrative space, operating expenditures, and looking at it by the number of people that do that program, allocates cost to it. Well, that can be very good when you have a revenue stream that is open-ended and that it's not a capped allocation. Child care subsidy is not one of those. There's never enough money, both either for the provision of the service of the subsidy, and there's never enough money to adequately administer it when we were doing it because of the overhead. that was attributed to that. We also saw that at this time, we were growing in our food assistance caseload. We were growing in our Medicaid caseload. This was about the time that the economy was going down the tubes. And we knew that if we were going to go and ask for additional positions from the commission, that would be a very difficult sell because that meant dollars, that meant resources. So this opportunity came to us, and when we ran budget figures, because of the funding stream and the uncapped allocation under income maintenance, which is the food assistance and the Medicaid program, we were able to realize savings of $323,000. Southwestern said, hey, we'll take the amount of money that the feds are going to give you and Smart Start are going to give you to administer the program, and we'll do it for that. That's all we'll take. That freed up 10 positions, 10 county positions, and then when we reallocated those 10 county positions to the mandated core services that only county government can provide, the feds say that you cannot contract out the administration of food assistance or income maintenance programs. It has to be a government merited worker that does that. So there's no way to get rid of that. So, we don't want to get rid of that. That's a bad choice of words. But when we reallocated those positions and the resources, it resulted in $323,000 in savings. Now that's a smart partnership in my mind, where not only the fiscal component is met in that we were able to save dollars and resources, but we were actually able to improve the outcome for the citizens that we serve, both in the child care subsidy world and in the income maintenance world, because we were not going to have applications time standards increasing an exorbitant amount of time because we didn't have the staff to process those. So it was a great example. I love that example. The other thing that we've done is using information technology. I feel remiss in not saying this sooner. The county has been extraordinarily generous with us, extraordinarily helpful to us in allowing us to have the freedom and the flexibility to create efficiencies, use our resources, and to be able to reinvest those resources where they need to go. I can't emphasize that enough, because what that has allowed us to do additionally, instead of doing things just like we talked about with child care subsidy, it's allowed us to engage and to provide the technology that's necessary for us to be able to serve more people with the staff that we have. We've been able to develop a case management system for child welfare. We've been able to purchase a case management or document management system for our income maintenance world that for the first time in the history of income maintenance has allowed us to not have each caseworker have five drawer file cabinets in their office full of paper files and over 100,000 file room to maintain those files. We're now completely electronic. We're reducing our file room footprint. We're reducing the amount of space that's required for a caseworker to have an office. We were even able to go to the state in this renovation and say, the state says a caseworker, this is an example, you have to have 75 square feet of space per caseworker. That's what you're required to have built, new space. Well, we went to them and said, but we don't need five drawer file cabinets in your office anymore. Will you give us permission to make the cubicle smaller, but really give the caseworker more space, usable space than they had before? They said, okay, we'll do that. There's a document that you'll see that alone allowed us to fit everybody that we needed to in Cox Avenue to be able to do that. That allowed us to do that. Now that investment, the county didn't have to allow us to do that. They didn't have to do that. There's no requirement. But that plus a management system for queuing, for patient flow, client flow, plus the investment that we're making in electronic health record for the health department has allowed us to be able to use efficiencies and use resources in a way that would be translated into additional space, additional time, additional resources that we don't have to be able to do that. finally, communication. Communication is a great tool. It's also one of the things that can trip you up the most. If you don't communicate well, you don't communicate often, and you don't make sure that those lines are available to everyone. Have we been 100% successful in that? No, we have not. We have done, I think, a very strong job, and we are building and continue to build the infrastructure to make sure that we communicate both internally to our board and externally to the community to be able to show what we're doing and to be able to continue what we're doing. Bottom line for us is that we focus on results that matter. That's where we're going to go. Everything that we're doing is about results that matter. We talked a little bit about this with our partnership with primary care in Western North Carolina Community Health and Minnie Jones Health Center. When we were doing that, it was an unsustainable model. We were spending about $4.5 million a year to serve 9,000 primary care patients. We were able to leverage, because of the full cost reimbursement model that an FQHC, Federally Qualified Health Center, has. They were able to leverage additional resources so that now they're serving for what, $2.3 million, they're able to serve 13,248. Now, where did that rest of that money go? It was reinvested. We reinvested that money in adding additional disease control nurses. We reinvested that money in making sure that the public health, the core public health that we are required to provide and assure was built up so that we could meet the needs that only we could meet. That's another example of being able to do that. And yet the beneficiary of that was not only the county, the taxpayers, but the patients that we serve, because now we're able to see more people. Still not enough. If you're in that world, you know it's not enough, but it's more than we could have done alone. So trust. I love this slide because it's really talking about building trust. Trust is built from a lot of different perspectives. Trust is built, hopefully, we'll build that trust with you, that you will trust the process that we go through and how we go through the process, and that you'll give us guidance so that we can further build that and cement trust that we have. It's also trust internally. Again, going back to the changes that we've gone through, it's trust to make sure that the process that we did for primary care was a process that developed and improved trust, so that when we went forward and did this initiative, that we had a solid foundation, and that we showed not only the community but internally that it was not a financial decision alone, that it was about making sure that the outcomes that we needed in this community were achieved. It's about building trust with the people that don't ever come in contact directly with our services, but through their tax dollars fund our services. It's about making sure that we are responsible, and by doing so, building a trust to allow us to do the things that we've talked about. It's about building trust with county administration, so that the county trusts us with resources and knows that when we get those resources, it's not about simply using those to spend money. It's about improving outcomes and access to citizens in our county. A critical component. So that's a foundation for you. So now we get into some numbers. So Health and Human Services for the FY 2013, this is going to represent what's in the county portion of the budget. So expenditures for social services, public health, PG&R, Parks, Recreation and Recreation, community contracts, and other services that we fund to support that, total $80 million. The county contribution to that is is a little over $40 million. When you look at that in perspective of the overall county budget, you'll see that Health and Human Services is the largest single component of the county budget. So that means we get a lot of attention, and that means that there's a lot of scrutiny. That means that there's a lot of accountability that we have for those dollars. And what you just saw has allowed us, the processes that we put into place, has allowed the county, and we built that trust and hopefully cemented that trust with the county in doing so. So we'll first start with DSS. Now, the DSS budget, I said it's a weird animal, because the DSS budget not only has county expenditures that are involved in it, but it also leverages additional resources from the federal and state government that are not particularly directly attributed to county costs. You see, under the total line, the total amount of dollars that it costs to administer and operate Buncombe County DSS for FY 2013 is $397 million total. And that's not all budgeted in the county. We get $282 million from the federal government. The largest part of that represents Medicaid benefits to citizens. But we are the agents that determine eligibility for those benefits. Remember when I talked about audits? That's the part that can keep you awake at night. That we have over $270 million in benefits that we issue. And if there are problems, if we determine eligibility incorrectly, if we provide something wrong, the state comes back to us and say, it's your fault. You authorized this. We just simply wrote the check. So thank you very much for the payment back. So we have a critical investment in making sure that we determine eligibility correctly, that we have the staff that's trained to determine eligibility correctly, and that we retain that staff to do that. Health and Human Services, I think, has done a tremendous job with the county's support, and Lisa's done a tremendous job in helping to support that process by training, development, recruitment, and retention, and the divisions have done a tremendous job in helping to work with their staff so that we make sure that we have a compensation and benefit package that recruits and retains the best and the brightest. And when they aren't performing up to standard, we move them on so that we can make sure that we don't have a problem with the benefits that we issue. State money, $90 million, although the state has the largest, we are a subrecipient of the state, so the state actually tells us we implement the policies that the state creates, and they contribute $90 million to that. The county, when you see the county budget, that's the number that is in the county budget, $23.6 million. That's the county contribution towards DSS. Well, what does that look like? Well, if you look at it, you know, I said this public assistance, that's food assistance and Medicaid primarily, benefits, takes up almost 86, a little over 86% of the total expenditures for the DSS budget. To administer those programs takes a little over 5%, about 5.5% of those programs. That's a pretty good return for administration of those programs. Well, if you were going to come to us, or the commissioners were going to come to us and say, cut your budget, we can't do this. Well, okay, but here's an example. This is not an example. This is real life. Of the budget that we have, the red represents we don't have any choice. We're going to do this. There's an example that Randy had told me a long time ago that said, you're going to pay your light bill. The county's going to pay the light bill before they do any. You're going to provide this before the county pays their light bill. You're going to do this. You're going to do these mandated services. Our optional services are very small, but they support those core services that if we did not provide those, our core services cost would increase dramatically. Revenue, just another picture of that graphically. You see 71% of our revenue is from federal, 23% from state, and 6% from county. Economic impact is a great slide. Economic impact of the benefits that we authorize in this county. And these multiplier effects are by national standards that we've researched to be able to determine, done this and determine what the economic impact of those benefits are. So we issued $364 million in benefits, either issuance or through child support enforcement through collections from absent parents. When you take the multiplier effect of that, in other words, for every dollar of Medicaid, you gain an additional 72 cents of benefit. So when you multiply that, the total benefit to the economic impact of this community is almost $622 million. So you see, there's any things that happen at a federal level relating to these programs can have a significant economic impact. Public health. Public health budget is very different from the DSS budget in the way it's structured. We structured the public health budget, again, by broad categories. And I should have said this with DSS. We look at the divisions that do particular work, and we group those functions under those particular divisions. We happen to call those accounting units, but that just says all the like functions sit in one particular area. And here you see, these are the areas that we have for health: community health promotion, clinical services, community protection and preparedness, regional health, and school nurses. You'll see, unlike what you saw in the DSS budget, the largest contributor to the revenues for public health is the county. A lot of mandates, but not nearly as many resources. So if you see a breakdown, community protection and preparedness, that includes our disease control area, which we believe is a very critical component, as well as our environmental health. And you see that that's one of the largest components of our budget. Clinical services used to be, when we were providing primary care, that we were not required to provide. Now we focus on family planning, breast and cervical cancer control program, and our Wise Women program that provide invaluable services to the community. We've also, since we contracted primary care, contracted our prenatal care services also with Immunogen's Health Plan. Graphically of how that revenue picture looks for public health. Majority, 62%, is from the county. Parks, Greenways, and Recreation budget. Again, a little different approach to that. You see, if I don't break it down for the county, you see that the largest contributor to Parks, Greenways, and Recreation is the county by far. In Parks, Greenways, and Recreation, the reason, as Mandy has said to you before, is that the county believes, and Health and Human Services believes, that there's a critical component related to health and wellness that Parks, Greenways, and Recreation provides, and that having that sit within the Health and Human Services budget provides a natural opportunity to both utilize the expertise of wellness activity, physical activity of Parks, Greenways, and Recreation, and allow public health and DSS to work more closely with them. Valley Child Care Center is the only child care center that we currently still operate. We used to operate others. That's one of those smart partnerships that we engaged with. We got out of the business of doing something that we were not the best ones to provide. But Valley Child Care Center is an example of where we partner and have the facility at a school so that we're able to help teen mothers who have had children to be able to attend that school and let their children attend that daycare. So it not only helps build the bonds with that parent, but it also keeps that teen mom in school and helps that teen mom to graduate. Recreation programs we have in place throughout the county. You've probably seen those. Maybe you've gone to visit the Festival of Lights at Lake Julian. If you've not done that, you ought to do that. It's a great thing to do and to help support Parks, Greenways, and Recreation. Lake Julian Park is one of those areas. That's not just Festival of Lights, but it's also a recreation activity that's very well used throughout the county, particularly in South Asheville. Zordner Center represents the indoor pool, Zordner Indoor Pool, as well as our 5 county pools that we have throughout the county. And Inca Sports Park is the soccer fields in West Asheville at Sand Hill Venable. We contract with ABYSA, who maintains those soccer fields for us. Again, another smart partnership. Well, you see, the largest contribution as a percentage of Health and Human Services is Parks, Greenways, and Recreation by county funding, almost 75%. Other areas within the Health and Human Services budget are community contracts. Community contracts represent those contracts and those services that we provide, that we contract with organizations to help support our core programs in Buncombe County, as well as what the commissioners have designated as programs that they believe support the sustainability plan that they recently adopted. So the process for that, just like anything else, those are performance-based contracts with specific outcomes that are measured and evaluated over time. Aging services, we contract again. We contract with Landau Regional Council to administer the aging services contracts and to administer the community care and development block grants for us as a county to allocate those resources across the county. Behavioral health is a large investment. Dr. Rich Munger is here somewhere. He is the leader of that program. $600,000 of that behavioral health budget represents our maintenance of effort that we are required, that every county is required to provide to the local managed care organization, formerly known as the local management entity, Western Highlands. So we provide that money to them. We designate those funds for specific outcomes so that we get specific results and monitor those results. In addition, the county also provides additional money that the county doesn't have to do towards, that we use a lot towards jail diversion services and for helping people that are disabled but are not receiving Social Security benefits to get into a program to be able to allow them to get those benefits. You'll also see in this document what we affectionately call the HISPI doc, where there's millions of dollars in benefits that come with leverage as a result of those investments. Human Services Support Team represents the functions that sit within Health and Human Services that provide the support. Those represent the HISPs, the planner evaluators that we call HISPs, to support the physical and programmatic components, and that have helped us realize, as you'll see in the document, over $7 million in savings and reinvestments in the cost of illnesses, both internally and in the community. And animal services. Animal services, you think, why is that in the Health and Human Services budget? Animal services, the sheltering component has always been considered a public health component because of the risk of disease. So this is for not animal control portion, but this is for actually a contract that we have with running the shelter with Asheville Humane Society. And we monitor that contract and have performance-based measures for a total of $6.3 million. So when you take it all together, the total impact of the DSS Public Health, Parks and Ways, and Behavioral Health, and the other category is $419 million. That's larger in total than the total county budget. You'll see here, next slide, you'll see an example of how we leverage for a $40 million contribution, not insignificant. I don't mean to not say that it's not significant, but for a $40 million investment that the county provides, we leverage an additional $379 million in services and benefits for the citizens of Montgomery County to get to that $419 million. Here's a breakdown of all of that together. So a little over 2/3 of the funding comes from the federal government, about 22%, and the county pays about 10% of those costs. Well, it comes back to trust. It comes back to building trust. It comes back to what is it that we do that has allowed us to hopefully have a positive impact on the citizens of our community. And it's been about building trust. And that can't be overemphasized because that's a hard-fought battle that you know in your own organizations. Building trust is a hard-fought battle and one that takes a long time to nurture and to continue. One of the things that we hope that within this board, that you will help us to further cement trust in the community. And that from what you've heard today and what you'll hear subsequently throughout your tenure as a board member will spur you to provide us with feedback necessary to help make our programs better and to help engage us in partnerships that you know that will help support the core services that county government is about. I'm going to give you one final example. At the first and the last combined consolidated board meeting, after that meeting, a couple of weeks later, Mandy received a phone call from Ken Putnam. And Ken said, I was listening to this board, and Ken is the transportation director for the city of Asheville. And so Ken was listening. He said, I was listening to this and hearing all the ideas that were coming about, and I thought about this one that we're in partnership with and discussion with MAHEC in particular, about providing transportation services for a medical corridor. So using the bus system, starting at Cox Avenue, and providing bus service that goes by Mary Jones Health Clinic, goes up to Mission Hospital, and then goes up to MAHEC. If you've been to MAHEC, you know, right now, MAHEC is not directly on the bus line. So we're trying hard to get, you know that very well. And so we're trying to get, work a plan to get that on the bus line. Well, what does that do? What a great opportunity. We have a strong investment in making sure that the citizens that we serve get to Mayheck women's, especially now, soon Mayheck family, because the contract that we have with Minnie Jones to provide prenatal health care services, we refer many of those high-risk pregnancies to Mayheck Women's to handle those high-risk pregnancies. It wouldn't be a good thing for those women to walk up that hill. So it makes sense. That's what a great example, and we're so glad that he came and brought that to us, for us to be able to engage in a partnership to be able to do that, because that helps not only Mayheck, it helps the community that we serve in general and gets it better. Those are the types of wonderful things that we hope and know that will come forward from this board that will engage us together. So that's the look at budgeting from a balanced perspective. I hope that I've talked the whole time. I'm sorry for that. But I would certainly entertain and love to have your questions and your feedback. We're going to go over one more thing after that. But does anyone have any questions that you'd like to ask of me? Yes, sir.
Why don't you count the difference between 2.3 million and 4.5 million in the primary care partnership as savings? You only said you recognized $323,000 in savings from that partnership, and when on slide 18, it looks to me like $2.2 million.
Well, and I apologize for the confusion. That may be, they're two separate things. The 323,000 represents 323,000 savings related to child care subsidy implementation. The difference in 4.5 and 2.3 for Western North Carolina, that, what we would call that is a savings/avoidance. So we didn't take that money off the table. It wasn't something that the county said, put that money back in fund balance now, thank you very much. It was about saying, okay, now how can we use those dollars to leverage additional resources, whether that was through additional staff within public health or particularly disease control, or whether that was looking at mandated service areas that we have, such as in food assistance, or taking those positions and being able to
I would say that serving 4,000 more people is certainly a savings that, in the long run, that you should probably calculate in that sum.
It absolutely is, and savings sometimes connotes that you're not going to reinvest those dollars. So we try to be very strategic in how we use those words, so that we don't connote that we're actually not increasing the level of services. But that's a very good point. Yes?
Does the state formula for the number and the amount of child care subsidies affect your federal funding for this program?
It's all federal funding. They take, this federal government gives money to the state, and then the state allocates that on a formula that they devise. They look at Steve can help me with this, but they look at that based on what your population is. They look at that based on the number of children that might be eligible for the program. They look at what your waiting list is that you currently have for children not able to get into that subsidy program. Those dollars are never enough across the state for the subsidy. The administration part, they've changed the formula drastically this past year. They said based on the census. But when we actually went back and looked at it, we didn't quite agree with what they were saying in their process. And so they were going to simply do 3% of it's a formula that they use.
Right.
And so through our partnership with Southwestern, they were able to work with the state to get the legislature actually to redistribute those funds based on a different formula, so that we wouldn't see the drastic impact that we had. If we'd seen that, it would have meant something had to give, something would have been reduced.
Got another one. I probably should ask Gibby this because it's in the public health budget. How do we get $150,000 revenue from contracts?
That represents contract that we have for school nursing from the state. The state gives us $150,000 to help fund our school nurses.
And that's not a part of intergovernmental.
No, it's a little bit different the way that they structure those dollars.
It's a separate allocation to the general assembly.
Okay.
Are there other questions that you have? Well, I'd like for you to, and I have no idea about the time, so please tell me, am I good, bad, indifferent?
Give you probably only got about 5 minutes.
Okay, that'll be perfect. So in your packet also is a financial dashboard. I think that you'll see a financial dashboard. I want to go over what you will see in your packets monthly. So it looks sort of like this, except you'll see it as a big page. We want to make sure that we give you the information that you need in order to understand where we are financially within the Health and Human Services budget. We realize that we won't have nearly this much time every month to be able to devote to the financial aspect of the budget, but we want to make sure that you have enough to make decisions and have an understanding. The Finance and Executive Committee is charged with going over the details of the budget, and we meet monthly to talk about the individual either strategies that we're employing related to the budget, challenges, opportunities, the whole strengths, weaknesses, opportunities, to be able to see at a detailed level. But we wanted to give you enough information so that you would know where we are too. So appreciate your feedback. This is an ongoing process. So what we wanted to do was to show you if the budget year represents 100% of the year, and we're at this month, at the end of November, we're at 42% of the budget year, then you could surmise, not always true, but you could surmise that our spending should be about on track with 42% of the budget year. So we break that down in salary and benefits, operating expenses, services, contracts, and other areas. And that's what you'll see in that little graph here. You'll see salaries operating. In this case, you're looking at DSS, salaries operating, human services assistants, and contracts. And to help interpret what you're looking at, the green background on the graph represents year-to-date spending last year for those particular areas. The bar that goes straight across represents 42%, in other words, where we are currently within the percentage of the fiscal year. And then the bars represent our actual year-to-date expenditures as compared to a percentage of the budget. So you'll see salaries are about right on target at 42%. Operating is a little bit low. Human services assistance a little bit is low. Contracts is higher. Well, we'll go over in detail with the exec committee the specific reasons for those, but I'm happy to go over that with you to tell you what those reasons are. A lot of it has to do with spending patterns. Sometimes you spend more at the beginning of the year, like with contracts, because we front end some of our contracts. And operating expenditures are lower because we had more expenses that happen in the later part of the year overall. And we also try to manage those effectively so that we don't, so that we have enough to be able to do some of the things that we've talked about today. And then to the right of that, we have, remember the accounting units, those are the broad divisions by like function, do the same thing. The green represents spending last year, the bar represents where we could be in terms of percentage of the fiscal year, and the individual bars represent where we are actual year to date. The only thing I'd point out to you is you see on child care subsidies, we spent 0% through the end of November. Please don't be alarmed. That doesn't mean that we've not provided child care subsidy. That line actually represents child care subsidy administration. Because of the examples that we had working with the legislature, we didn't do anything with that until we were firmly solid with what our allocation was. Now that that's done, you'll see in December's results that we're current now through the end of November in our contract. That represents our contract with child care subsidy. So any questions about that format? Does that format seem to work for you? Are there any things you'd like to see differently or clarity on that? Okay. Then you'll see the same thing for public health. Now, contracts, after I got through saying that we front end some of our contracts, you'll see contracts for public health is way low where we are. That represents, a lot of that we have in contracts are for specific initiatives that we are either in the process of developing or have not implemented yet. So regional public health, just to point out where that's low, the regional public health is what we call the state lab. If you have heard, North Carolina just built a new state lab in Raleigh and it will replace all of the regional state labs. So this state lab is actually closed now. And all the great facility in Raleigh that they built with considerable space for expansion. So that's what that is. And then if you look at Parks, Greenways, and Recreation, you'll see where we are. Grants not being spent because those are processes that they're just now undergoing and sending out requests to get those grants. And those are grants that they allocate to organizations in the community.
That means that none were funded in the prior year either.
It means that none were funded at the prior year at this point in the year.
Or at this point.
Yes, they will be. They just do that in the spring. I'm happy to answer any questions that you might have.
I will say this, you can see that Jim is a walking encyclopedia when it comes to what's going on with human services. Jim, thank you so much.
Well, I say this, it's a great team. It is a great team.
I understand that, but it has to wedge into your brain and you do well with it. I will say this, that as you absorb all this, please understand what he said. There is an executive committee, and we meet monthly, and we go over this thing in depth. So a lot of things that you will hear, you won't have to worry about all these figures and everything. We will do that in the executive committee, and then we'll bring you recommendations and things of that nature as we go through it with you. I would also like to say this, that listening to Jim and on this report, all this program and everything was set. It's been a 10-year game. It has been a building set up that has lasted 10 years to work. We have a very good financial situation and program here in Bucks County as far as the health and human services are concerned. And we have every reason to be proud of it. And we'll keep you informed. And once again, if you have anything that you want to help us with, we'll be more than happy to listen to what you might want to give us. Let's see. Okay, that brings us to Gibby. And Gibby, one of the things that we'll do in the board, we have to approve various things and policies and so forth. One of the things that the county has been making sure that we do as far as human services is concerned, try to get information to the board before it goes out. And so what Gibby's going to do is present that to you at this point on something that's going to come out, and she wants us to have it before it comes public. Okay, Gibby.
And although we try to get it out to you ahead of time, I did not send this PowerPoint ahead of time, and I did that for a couple of reasons. And the main one being I didn't want you focused on the data today. I want you focused on the process and what we're going to do next with it. I'm going to give you some data just to give you a broad stroke picture of what's in the community health assessment, but I didn't really want people diving into the data. I've actually done a couple of presentations so far, and that's exactly where people go. And if that's where you want to go, that's fine. But that was the rationale. I'm not sending this out before. Assessment, as you can see, is one of the core public health functions. And in North Carolina, local health departments are required, both by statute and by accreditation, to do a community health assessment every 4 years. So hopefully that's not a new concept to you. Hopefully you've had the opportunity to look at community health assessments in the past. And they're usually due in December, and what the state does is break us up into 25, 25, 25, 25, so they're only reviewing 25 a year. There's a community health improvement process that we're part of, and it starts with the assessment. So the assessment is the first part. It's not the whole process. The collection of data is just an opportunity to help you work with your community to figure out what your priorities are But then you've got to put together an implementation plan and implement it and evaluate it. So it's an iterative process. It doesn't stop in between the 2 4-year periods. So in 2010, these were our community health priorities. I'm not going to read them off to you, but I guess the point here is we just did one in 2010. It's not 2014 yet, so what's different? Why are we doing another community health assessment? The Affordable Care Act put out a separate requirement for nonprofit hospitals that they do a community health needs assessment every 3 years as part of their community benefit process. That community health need assessment is supposed to drive where they put their community benefit dollars. So there's been a lot of encouragement, especially in the state of North Carolina, but across the country, for health departments and hospitals to figure out how to work together on this. The last thing we need is the health department to put out a community health assessment that has this set of priorities, and then the hospital to put out a different one that might use different data with a separate set of priorities. It's confusing for the community. It doesn't really help us move forward on any particular issue. So we decided that we would work with Mission, our main hospital here, but also Care Partners, which is a nonprofit hospital, and we work with the hospitals in Henderson County as well, although not as closely because they do provide some services in the southern part of the county. But we are focusing with Mission to do a community health assessment that will allow us to meet their timeline that the Affordable Care Act required. We bumped up our process by 2 years to do that. But in addition to that, we decided instead of doing one just in the county, that we were going to do a regional community health assessment. So we have a 16-county area in the western part of North Carolina, 16 county health departments, 16 hospitals, who have worked together over the past year to do a community health assessment on the regional level. And what that entailed was a long, painstaking process of agreeing on a secondary data set of morbidity and mortality data that we could all agree was necessary for the assessment, as well as a solid survey on primary data, which we did through a telephone interview process that every county in western North Carolina has. So the assessment that you'll see on our website will look almost exactly like the assessment on 15 other county health department websites. The data is put together the same way. We now have regional data so we can compare ourselves against regional data. And we're hoping that we will come up with 1 or 2 priorities across the region that we can work together regionally on. So that's not just the health departments, it's the health departments and the hospitals. That's a really important piece. So this process is moving forward. Again, opportunities to compare across county lines, but also to look at how the hospitals may share some of these resources to impact things on the regional level. So that's why we're doing one in 2012 when we did one in 2010. The community health assessment has 6 broad data areas. One is demographic socioeconomic data, and you can see the issues that are included under that. Health status, it looks at the community health rankings that we receive from the national level through Robert Wood Johnson and the University of Wisconsin every year, along with these other issues that we're looking at. We have health behaviors that we look at, as well as clinical care, demographics and data, physical environment, and quality of life data. In addition to that, the document includes a gap analysis of services in our community and then the prioritization of issues so we know what we're going to be working on over the next couple of years. So I'm not going to share all of that data with you. We'd be here till Christmas. But what I am going to do is share some data with you that's specific to the priorities that we had before, because that was one of the things we wanted to look at. Priorities don't change in 2 years. They don't change in 4 years when you're looking at some of these big issues that we're looking at. But what we wanted to do is look at the data in those specific areas to see if our priorities still remain what they were before. And that's what I'm going to share with you today. So leading causes of death, what you have here is Buncombe County rank and rate, then Western North Carolina and North Carolina. The 3 things just to point out here, ours are fairly similar to Western North Carolina and the state. Some of the differences, chronic lower respiratory disease, we have higher rates there, as well as Alzheimer's disease and suicide. Just issues for us to pay attention to. But you can also break that down by age group. And again, you'll see the similarities across Buncombe County, Western North Carolina in terms of the leading causes of death. Although when you get to the 40 to 64-year-old age group, chronic lower respiratory disease pops up for Buncombe County. So again, something for us to pay attention to. If we look at the area of healthy mothers and healthy babies, the message behind this slide is number one, any teen pregnancy that's not planned is too many, number one. And number two, we have huge disparities in this area. Many more African American girls and Hispanic girls giving birth in North Carolina. Some of that in the Hispanic community may be cultural, but we do know that pregnancy in our teens impacts birth outcomes, and that's something we need to pay attention to. Gonorrhea rates by racial ethnic groups, and again, we have data for North Carolina and Buncombe County. Number one, our rates are higher across the board than North Carolina rates, but you can also see the huge disparities in our African American community, which greatly impacts how we focus and target the services that we provide, the populations that we need to focus on. When we look at the area of healthy living, it's no news to anybody that obesity is an issue in our country. If you look at this, the total overweight population in Buncombe County, 62.6% of the people that were surveyed, when we asked them about their BMI, fall into the overweight or obese categories. And the obesity, which is BMI greater than 30, was 27.50%. These came from the survey that we did. We contracted with PRC, which is a national organization that does data collection, and there's one of their specialties is doing telephone surveying. They did the same questionnaire across all of our 16 counties. They did sufficient numbers in every county for the data to be statistically significant. So that's where this data came from. So this is self-reported data. When you look at heart disease mortality rates, that was one of our top three. You can see Buncombe County is a green line. We're seeing improvement there. Something that Frank and Winnie through Mission work on every day. Your work is having an impact. That's a good thing to see. But as you can see, we still have more heart disease in this community and deaths from it than we need to have. So still area for focus. Cerebrovascular disease, we see sort of the same thing. We're a little just barely higher than the regional mean, but again, it's for us. When we look at diabetes compared to Western North Carolina, and the U.S., our diabetes rates are higher as well. You know, we've gone from a country of dying from communicable and infectious diseases to a country that's dying of chronic diseases. And we're having to shift our focus in the work that we do. We can't let go of focus on the communicable diseases. That has to stay in place. But we really need to be paying more attention to this. And a lot of that's being driven by the obesity epidemic in this country. This was rather distressing. When you look at how many people said that they had an average of 5 or more servings of fruit and vegetables a day in the past week, in Buncombe County it was 9%, and in Western North Carolina it was 8%. So we've got plenty of work to do here. And this question was interesting about how many people have worried in the past year about food running out before they had money to purchase any. And if you'll look at this block over here, over 25% reported that that was sometimes true or often true for them. So when we're talking about food security, and we're talking about people eating healthy fruits and vegetables, which are usually more expensive than the potatoes and rice and the pasta that people can get, this is an issue for us too. A couple of slides I threw in just to let you know, especially with the work that's going on with parks, greenways and recreations around some of the built environment. There's good support in our community for trails, parks, and greenways. There's good support in our community for physical activity spaces available to the public after hours. So we're trying to be creative about making sure that we have these spaces in our communities. And then access to farmers markets and tailgate markets. There's support for these things, we've just got to figure out how to make them happen in a bigger way than they already do. When we look at children's health and school readiness, again, the overweight and obese issue pops up, obviously, in Buncombe County, and this is not self-reported data. This is data that comes from our school systems every year. We have been tracking BMIs in kindergarten through 5th graders for over 5 years in Buncombe County in all of our schools. And as you can see, 44.4% of our kids are either overweight or obese. And if you saw the numbers with chronic diseases and they look bad now, if this continues, they're just going to continue to get worse. And that impacts all sorts of things, whether it's the hospitals and the people that they're having to take care of there. The healthcare costs just continue to go through the roof. The need for access for services through DSS, all of those things are impacted by these numbers. When you again look at this is indication of poverty for children under the age of 18. We often do this in 5-year increments because it takes some of the instability out of data. The first set is 205 to 209. The second is 206 to 210. You see the numbers starting to creep up, and when we look at these last 3 years, we know that those numbers will go up even further. Average wait list time for children for child care subsidy in Buncombe County has gone up over the past year. So the availability of those dollars and the need for it, when you put those two things together, the wait time has gone up, and the number of children enrolled in licensed early care and education programs has gone down, which is directly related to the fact that those dollars aren't available to everybody that needs them. And when we're looking at child development and readiness for school, this is huge. Access to care, interesting enough, the majority of the people in Buncombe and even in Western North Carolina consider cost, quality, number of options, and availability that we have a good child care system in our community. So that's positive. But then if you look, especially at our adults 19 to 64, we still have quite a few people who don't have health insurance. We're hoping that the Affordable Care Act will help with that, and then we're hoping that the medical care community will be able to accommodate all of those extra people that have insurance. Access to care, this looks at the primary reason for inability to get medical care and mental health services. Healthcare, the majority of it is cost or no insurance. There's lots of different reasons for mental health, and there's lots of different reasons why those are reasons. So again, this is one of those areas where we probably need to dive into the data a little bit more, do a little more exploration to really understand fully what some of the answers were and what we might be able to do about some of those things. You saw that I put the chronic respiratory disease. It showed that it was one of our leading causes of death, especially in that middle age group. As you can see in Buncombe County, our numbers are higher than regional and state, and it's just another reason why we really need to stay focused on the issue of tobacco. It didn't rise to the top as one of our primary priorities through our community health assessment, but we know it's one of the leading causes of death, and it's the leading cause of preventable death in the United States. So the line is the Healthy People 2020 target. You can see that we are in better shape than the state and in Western North Carolina, but still have a way to go to meet that target. And this is smokeless tobacco products. Western North Carolina and Buncombe County are ahead of the United States in that area, and that's again an area that we need to stay focused on, especially with our youth. And if you remember the dollars that were taken out of the master settlement to focus on tobacco use in youth and preventing tobacco use in youth was wiped out by the General Assembly last year. So again, we're having to stay focused on that and figuring out how we'll continue to bring that down, because we have seen a significant decrease in our youth in tobacco use. But with the dollars going away for that prevention work, we'll have to keep on top of that. So what we did is we took those 6 priorities that we had before and we repackaged them a little bit and made them a little more specific. These are the proposed community health priorities for moving forward for the next several years. Women's preconception health. We have seen significant improvements in infant mortality over the years by increasing the availability of prenatal care, getting women into prenatal care, but that's sort of leveled off a bit. And what we're seeing, the data is showing is that women who are not healthy when they get pregnant, even if they access prenatal care, do not have really good birth outcomes. So improving the health of a woman before she decides to get pregnant including things about spacing pregnancies and making sure that it's an intended pregnancy. All of those things fall into that category. Healthy weight, healthy living, obviously there's lots of work that we need to do there. Children's health and early child development, all of the data that's coming out is really showing that if you don't focus on that when these children are young, they will not have the outcomes that be the productive individuals we need them to be as we move forward. And then access to primary and mental health care is an ongoing issue for us. We're in better shape than lots of others in the community. We rank third in the counties in North Carolina in terms of access to primary care, but we still have issues, so it's still important to do there. So what's next? The Community Health Improvement Plan. I told you that the gathering of the data was just the first step. Now it's the hard part. What do we do with it? How do we decide what we're going to stay focused on? So we're with Mission and other partners in the community, the county is going to implement a process that develops this plan, which is more specific than the planning that we've done in the past. It's fairly targeted, where you actually develop strategies, you establish accountability, and develop measures around the strategies that you're going to watch so that you can look at them over time. It really coordinates and targets resources, and it helps us look at all the different contributions that all the different entities in our community bring to bear on these issues. So the contents of this plan: goals, objectives, strategies, performance measures, a realistic timeline, designating roles and leadership around the different issues in our community, requiring that those organizations demonstrate commitment to the role that they've agreed to play, evidence-based practices, making sure that the dollars that we do spend, we're spending on things we know work, and then how do we sustain that action as we move forward. So that's where we are with the plan right now. The plan is over 220 pages long with lots of charts and graphs. Good bedtime reading. But it's also set up on the web in a way that if you go to the table of contents, there's specific data you want to see, you click on that, it takes you to those pages. So hopefully it's user-friendly. And this is the website. I will send this PowerPoint out to you, have Krista send it out to you, so that you've got the website and those slides if you particularly want them. But there may be other data in there that's of more interest to you in the work that you do, and we want to make sure that y'all have access to that. So we'll be moving into the Community Health Improvement Planning process after the first of the year, and there will be lots of opportunity for all of you to be engaged and involved in that process. Any questions?
Thank you. Well, the next is we get an opportunity to hear from public. And Jerry Rice, come forward, Jerry. We'll give you 3 minutes.
Thank you, Mr. Chairman, members of the board. I certainly am pleased to see the television set up for the committee. We brought this to your attention a long time ago, Commissioner, and I think it's a great move in the right direction. The thing that I come to you in a more common sense way, I'm not an agency person, I'm not a professional person in the field that you're in, but I deal with parents on a personal level. And one of the things that I would like to share with you is that it needs to come down on a common sense level at some point in time in a board meeting where the general public is understanding what you're doing, not that you look good, you're speaking well, and you got pretty graphs. Most common people are the one that sits in front of you at your desk in your agencies, in your hospitals, in your schools. And one thing that's probably missing that I find is that the one that's sitting in front of you has got a little more brain than you think. They have got a lot more answers and questions and concerns that would help your agency if you only had a way to get it. And so I hope that this televised presentation, and as you get into it, you present things that are common sense that the general public is going to pick up on. There needs to be a newsletter that goes out to each client, I'd say, that you serve, and have a way of communicating back and forth, even on a blog or some way, because technology today is very useful. And if each department and agency did that, I think we'd get a lot better surveys than what you get from these national companies, because every community is different, as you know. A hospital has a different way of operating than other agencies. When you see the heart center being bought out by the hospital, when you see the hospital building a cancer building, big one, then you know that there's something pretty big in the community going on with those two things. It's not rocket science. So what I would suggest is, how do we get to the common person? The people I talk to that comes to your agencies and your hospitals and your place of business, they come back and tell me and give me a lot different information than you're getting, because trust. The word trust you saw many times mentioned. Until you gain the trust of that person, you will not get sufficient information to go forward with what you're doing. If you're always telling them what you're doing instead of asking them what they need, then you're not going far. Thank you so much.
Thank you, Gary. We'll take that into consideration. One thing that I would like to remind the public as well as this board is that we're in an orientation session. We're learning as much as we can about what goes on within health and human services. So we're doing a lot of lecturing, a lot of PowerPoints and things of that nature, so that we'll be up to snuff whenever we start doing what we have to do as a board. So at that time, Jerry, maybe we'll be able to, hopefully we'll be able to communicate as you're indicating. Anybody have any questions? Do I hear a motion that we adjourn?
So moved.
Got all kind of way in that corner. All those in favor, you may leave. Happy holidays, everybody.